Testing. Oh, it works. I just have a question having to do with with if you have like a contracture where you're like people in wheelchairs, they've been in wheelchairs for a long time and they typically have, even if they don't have any like spasticity, but they get shortened muscle ligaments. Is that something that what you were talking about with that material that you can inject, can that be like baclofen in the sense that it relaxes that or the tendons and makes it mobile again?
For tendons and tendon sheaths, it will definitely, if there's a contracture that's kind of a stuck place there, it'll open that up. In other areas, if you have a ligament, so Wolff's Law says whatever stress you put on a physical body, the body's gonna conform to that. So the shortening of those tissues is usually a little bit of a different process, and so it's not the same as for hyaluronidase. However, that's the place where, and that's the kind of contracture that collagenase will do a pretty good job with. So we put that into that area for that purpose.
And that can help loosen it up and allow it to,
Yeah. In fact, it's FDA indication is for those kinds of contractures.
And is that done just like you inject it in there and then it does its thing, or how does?
Well, we wish. No, it's location. Like you have to really know. Like so you're mostly collagen. And so if you just randomly put a collagenase shot in a person, you're not going to get a good result. You're going to get a hole, basically, in that collagen. So you want to pepper it into that area, and so we do it kind of in a very specific manner, and you get right at that location. So generally, we'll use an ultrasound to identify that and to make sure that we're not getting it anywhere outside of that.
Okay, thank you.
All right, perfect. And if anyone else has any questions, I don't know if you heard Rhonda before, but feel free to raise your hand. I'll bring the mic over to you, and then feel free to go ahead and ask. So any other questions right now? All right, perfect.
Those may not be the best shoes for this job.
I have a few questions, so we'll just start with, okay, whenever you guys were talking about stem cells in conjunction with HBOT, when you're doing a few dives, going to get stem cells and coming back, the way that because we're a year and a half post-injury right now, and we're doing stem cells leading up, HBOT leading up to stem cells, going to stem cells, and then taking our 30-day break after that, or including the stem cell time in that. What I heard today was that maybe we should start to where we fall about halfway through the 40 dives, go get stem cells, come back and resume. Do you guys think that would be the better way to go now than doing 40 dives and stem cells?
Well, yes, and I only say that based on what's happened and all that information I put up there. So those human cases, the animal studies and all, what seems to be suggested is that some before and some after, or you look at some of those studies in the animals, they just did it for 1 or 2 treatments afterward. Others did more. It's a wide variability there, but the net message is that some before and preferably some after may help implantation. And what we found out now was just happenstance. The first parent who said, we're coming down to see you and get hyperbaric, but we also have scheduled a visit with Dr. Proefrock, and it's right in the middle of the time we're going to be down there. I said, well, that's interesting. That's the way this probably could help the most. And so now it's just happened and unfolded that way that a whole series of patients have done that. And the ones who've done the least, or one of them, was just a week. They came down for a week and they got that same 340, 380 million stem cell harvest that the others who had 2 weeks. So I can't tell you the best is at halfway necessarily. Halfway is generally the time by which we start to see noticeable changes in many of the patients.
Okay, so that leads me to another question that I have talked to some of these parents that have gone this route, and a lot of them weren't able to complete the treatment, the HBOT treatment. What do you guys feel about that?
they were not able?
Right, so say they did 10 dives, went to go get stem cells, because when we saw you, it was 40 dives consecutive, and then we took a break, right, or over 8
Yeah.
weeks. So some of the parents that I had talked to did their dives pre-stem cells, went and got stem cells, came back and couldn't finish out the 40 dives. But, so I guess in our case, we would have to be, I'm wondering what you guys think about that, but then also how would someone in a home setting be able to identify clinically when it's time to stop?
When it's time to stop
Right.
the hyperbaric treatment
Right, after stem cells.
after stem cells.
So
Okay.
am I right
There-
that
there's
some
no set
children
number.
did
That's
it
what I'm trying to
complete?
tell you. It is not, I gave you pretty much all the information that we've got and that's been published, except for, distilling down all of our patients that have done this. First patient of mine that got stem cells was 1998. There have been a whole bunch of them. They've gone everywhere, India, Russia, you name it. But we don't have follow-up to know, well, which ones did it best when, until this more recent group. And the more recent group are mostly children who have had a drowning or birth event, and they're not down the road a long time. I mean, they're still in that subacute period of time. So even then, they don't necessarily require 40 treatments. That was what was established with chronic injury. It can be less.
Okay.
And so you just follow them clinically, and there's not an easy answer to that, okay? That, again, the principle is, and what seems to be supported is, if you can do some before you get the stem cells and some after, and then fit that into your overall plan, that seems to be the best way to stimulate production of stem cells for harvest, and also maybe to implant the ones that get administered. And even, as you saw from this, stimulate them from the bone marrow and so on. So it's not a set one that I can give you right now, just a general guideline.
Okay, so that leads me into another question. Dr. Proefrock, whenever we had spoke or last year, was it last year? No, February. You said that you liked the idea of layering stem cells. Now, we had an incident with the intrathecal infusion, so we're not really wanting to go that way anymore. But I keep going back to you saying you like layering different stem cells. Now, could that possibly mean not where they're derived from, but how they're put back in the body, such as IV or IM? Is that what you mean?
It's tricky because we are in the infancy of understanding how some of these things work. And so who's to say that do adipose stem cells do the best job? And applying the way that we apply them, is that doing the best job? Well, the only way to know that is, well, did we do different ways? And so people like Host or Panama or World Stem Cell Center, these places, they have different quirks, different ways that they work it. I talk to them all very regularly, and we're all in the same boat, which is, well, does that work better? Why do you think so? And how do you know? And the honest truth is, we won't really know for probably a few more years what that really is. So at this point, we're in the place of, look, if it's safe and we're still accomplishing the same objective, yeah, let's try different ways, because I'd like to know what the best way to do is, because if I found a way that was better than the way I was doing it, I'd jump on the bandwagon.
Can I ask one more? Okay, sorry guys. Okay, so
We might have to get you a chair up here.
this one is for you, Dr. P. So when you were talking about the PRP shots, you were saying, and I didn't write down what the slide was relative to, but I was wondering if, and I know that this is probably a long shot because there's a lot of stuff that we can do in the acute phase that would help our children not deteriorate in their conditions, but the PRP in the acute phase of a brain injury, I don't know, I kind of felt like you were leaning towards that might be something that we could do also in the acute phase to help.
So we have to redefine some part of the term, okay? Language always has a hard time keeping up, I think, with our understanding. And so PRP is a generic term. It doesn't necessarily mean that you have you're desiring a platelet-rich plasma because platelets do cause more inflammation. Platelets also, though, help restore a blood-brain barrier. In an acute injury, the objective is how quickly can we get that blood-brain barrier restored so that we're being able to be selective about what comes in and out of a nervous system. The PRP, as we standardly do it for, say, joint stuff, is too inflammatory to do that. So generally, that's not very platelet rich. It's still a concentrated plasma, but really what we're looking for there are some other constituents, some growth factors, some anti-inflammatory elements that we can then put up intranasally with an enzyme to try to start restoring that blood-brain barrier. That's what helps take us from that acute storming kind of a place into a more subdued place. If a person's constantly having seizure activity because of exposure of some environmental influence or because their blood-brain barrier just isn't being able to be selective, then that can make a big difference.
Perfect. And we have a question back here as well. So let me bring it over to y'all as well. Here you go.
So first, let me say that the brilliance on the stage right now is immeasurable, and we really appreciate it. So my question comes with the battle between alternative therapies, which I think we all agree that you guys live in, and the medical model, and how some medical interventions I have felt have been necessary for my daughter are also adding on to part of the problem. So she's on, psychiatric medication so that she can be in a school setting, but the blood pressure lowering medications that she's on are affecting what I think is getting more blood oxygen to the brain. So I just feel like I'm chasing my tail sometimes with medical interventions, and I don't know what your thoughts and feelings are when our kids are put on these things. Are they obstacles to healing, or can you work with us as parents whose kids have had a lot of medical interventions to kind of help them? Can they heal with all these barriers? That's what I'm asking.
They're tools. They're all tools. Baclofin's a tool. The question is, does it do the job that we'd like it to do? If it's doing the job, all right, let's keep it for a while. If it's not doing the job, we got to bail. They put kids on gabapentin. I don't understand that. They've got pain. Gabapentin is the worst thing on planet Earth for your memory, just about. If anybody as an adult has ever taken it, you realize, wow, after 3 weeks, you don't even know your name anymore. Why would we do that to a kid who's having developmental issues? So that may not be a very good tool. And now, could there be situations where you might draw upon that tool? Sure. If a person's trapped in, as a consciousness in a body that doesn't do the stuff that they'd like it to do, that's endlessly frustrating. So yeah, there's going to be some psychiatric complications there. So if we put somebody on a psychiatric medication for that purpose and they are better for that, all right, then we won. If they're not, then we're not winning. My beef with the way that the medical system kind of works this is, on average, the kid who's had a brain injury is on 8 different drugs. And not all of those make sense. They're a one-size-fits-all recipe. It's not one-size-fits-all. As we talk about with the research part of it, 10 kids, 10 different presentations, even with the exact same injury. That is not conducive to a one-size-fits-all kind of a strategy. It's lazy. And I will tell that to the neurologists. Why did you put that child on gabapentin? Well, I thought they had some pain. Really? And do you see any difference from that? I don't think so. Then take them off. Otherwise, you're being lazy. I will take them off. I don't have a beef against a lot of those drugs. If they do the job, if they're a good tool, they're a good tool. But remember, if you go down and buy a really fancy titanium hammer to fix your window, and you decide you're just going to prop that window up with that hammer, is that the best use of that tool? Because then every time you want to open the window, you still got to prop it up with your fancy hammer. Or you could use the hammer to actually fix the window, and then you don't need to leave it there anymore. That's our point, is can we do something that actually changes the trajectory so they're not on these drugs for the rest of their life? if they have to hold a space there, I mean, a lot of our kids have seizures. Seizures suck, you know? Not all seizures are completely bad, right? But you could lose a lot of good neurologic activity because you've got this current going through destroying tissue. All right, we got to mitigate that. Until we figure out a better solution, we just got to do what we can do. And then you keep working, and you don't stop keep working. You just keep trying until you find a better solution for that individual. But what works is what works. What doesn't work, bail. Don't keep doing that. And if the neurologist is demanding that this is the way it goes, find another neurologist. Because if it's not logical to your mind, it's your child, then you don't have to abide by policy. It's your child. You know whether it's working for them or not.
Yeah,
We
and
also-
you know, we kind of start with one, and then now we're adding another because of the side effects of the first, or adding a third,
Call it the
or
medical
adding a
conveyor
fourth,
belt.
And it's madness.
Well, I think we also need to acknowledge what the goals and expectations are of the medications. It's very well established that medication is not going to integrate or grow or mature a brain. That's very well established. So if our goal is to actually change a brain, if our goal is to integrate a brain, if our goal is to actually get to the root of the issue, then we're not going to do that with medication. I'll stand on my head and say that. I'll say it to anyone in the room. I'll say it to anyone in the medical field. It's not going to work. But like you said, it's a tool. So if it means that we have a child that's suicidal, if we have a child that is going to hurt someone else, if we have a child that, you know, whatever it may be, and we need to use something like that in the interim, then that can be a positive thing. However, we don't want to lean on that for healing, right? Does that make sense? Now, just for example, like I used to be, I was on gabapentin for a little while. It was in high school. I had a severe injury. They put me on gabapentin. I felt like I was a zombie. It was terrible. I actually took myself off of it as a high school, aged kid. Another thing is like I've got a pretty bad thyroid, and I tried everything under the sun to heal my thyroid. Well, it didn't work because stress affects me so much. When I took a sabbatical and lived in Costa Rica for 3 months, my thyroid normalized. Okay, that's great. So there you go. So I know how to fix my thyroid. I just need to go move to Costa Rica. But that's not realistic. So I stay on thyroid medication. You see what I'm saying? So there's tools, but we have to understand goals and expectations, and we need to mitigate what we can mitigate and work around it and integrate what we can integrate.
Yeah, which brings me to my second and last part of the question. So, and as a parent, I feel like sometimes medical insurance is like, handcuffs, right? So it's like we're kind of drawn to that because I know I can get rid of the symptom for $10 at the CVS. What can we do as parents to make sure that these therapies have better research, that these therapies get the peer reviews so that hopefully someday we can all afford them and they're more readily available?
Well, Canada pays for what we do. For what I do, I send a super bill to, if it's a Canadian citizen and they come down, most of those kids get paid for. In fact, I have a letter from a Canadian Health and Human Services Department, which said that this therapy was more cost effective than all of the things that they had been doing in terms of the progress that the person made. So we just have to get the United States to be on board. But remember, I was a chemist for Procter & Gamble. On the wall, in our lab, they told us, remember, you work for the stockholders. And remember, you're a stockholder. We are creating 30-year relationships with our consumer base. That's what's best for the business. I made a product, my last product, because I left afterwards to go to medical school, which was a cholesterol-lowering drug. It was basically an agent that increased the receptor sensitivity for LDL, which is the bad cholesterol, in your liver, so that if you made too much bad cholesterol, your liver knew it and would stop making that. It worked beautifully, so beautifully that you had to take it for 6 weeks and you didn't have to take it again for maybe 2 years. They shelved it. They shelved it because they said, this doesn't meet the criteria. We want a product that somebody's going to take, and we want a 30-year relationship with our consumer. So we consume more pharmaceuticals per person in the United States than any other country on the planet by a long shot. And insurance pays for most of that. Do you know that we are now lower than 27th in the world for relative health of the average individual in the United States, that last year Chile went above us when their expected death rate became 82 for males? Do you know what the expected death rate for males in the United States is? It's 72 years old. You get 7 years from the day you retire, and then it's curtains for you. Why? You know that the average number of pharmaceuticals that the person over 65 in the United States has put on is 5. It starts with your cholesterol-lowering medication as a menopausal woman. And then when your cholesterol is low, as coming down, which is the way that you make all of your hormones, now your menopausal symptoms are worse. So now what happens? Well, you can go on some hormones, you can go on an antidepressant. The antidepressant does the thing, but now you've got another issue. Now you've got another issue. Now your blood pressure's up. We are adaptable creatures. We can take most people in a sports medicine context who are able-bodied, and we can get them within 6 weeks to be able to run a marathon. They may not win it, but we can get them to run that. You know, we tend to be very, very short-sighted as a population. We paint ourselves into corners. If you take a blood pressure pill today, I'll guarantee you that in a year to 3 years, you're going to need a higher dose of that. As we talked about before with accommodation, we will accommodate to whatever we do. An intelligent monkey would say, your best bet is to anticipate what your accommodation is going to be to this thing, and then do something different to get your body to accommodate differently. Now, I have a bias, of course, because I find that a lot of agents that are in the over-the-counter botanical medicine, nutritional supplement world, they do a nice job of adjusting physiology. If you can adjust physiology in an artful enough manner, you can help a person not just control their blood pressure, but also make it so that they don't need to keep taking something for that over time. With a child, they're going to grow, they're going to develop, they're going to remodel their nervous system according to their environmental constraints. So the medications we put in them are part of the environmental constraints. Do you want your child to be as brilliant as possible? Then don't put them on stuff that makes them dumb. That's really the bottom line is, what's the best use of a tool? You know, if the tool's necessary, absolutely. But most of these tools that you're given do not come with an exit strategy. The expectation is you're broken, you'll be on this for the rest of your life. Whether it's a blood pressure medication or a Caesar medication, I have a patient right now who's 46 years old. She had a birth injury. She's been on Tegretol and Depakote since the day she was born. 46 years she's been in a vegetative state. Her liver enzymes started climbing up. Her mother, who's been a long-term patient, had breast cancer 10 years ago and survived. She says her liver enzymes are getting up. Do you think we need to move to another anti-seizure medicine? I said, you know, when's the last time you even saw a seizure? She says, I don't think I ever have. I said, really? Let's wean her off of these. So we weaned her off the Depakote and the Tegretol, and you know what? She didn't have a seizure. And you know what? She's starting to be vocal for the first time in her life. She's raised her arms above her head for the first time in her life. She is being engaged with her family now for the first time in her life. And her mother, with tears in her eyes, says, 46 years. 46 years. She says, they scared me so much, they said that she would have SUDEP. You know what SUDEP is? It's sudden, unexpected death from epileptic process. That's ugly. They did the same thing to Asher's parents. They took very circumstantial data and they scared the crap out of this poor family to say, no, your child could die any day, any time. So you listen to us so that that doesn't happen. Oh, that's crap. I'm sorry, but that is untrue and it's unfair and that's a bullying tactic. If you're in a position of authority and you use that to coerce people to do what you want them to do because you think that's best, that's bullying and you need a new doctor.
Let's go, Brandon. Just saying.
So your question, though, is how to get more studies, how to get reimbursement, and so on. That is such a long, slow process, unfortunately. And the best you can do is marshal the evidence you've got for what you do. And if you document very carefully and have independent documentation of it, then submit that to your insurance company. You're going to have to fight them, though, because they'll have, usually they'll reject it, and then it goes to review. And there's a way to go about doing this. There's a book called The Insurance Warrior, and it's about a lady who had I think it was a carcinoid tumor. It's a cancer of the appendix. It's very rare. And she was in an HMO, and she wanted to get the surgery by someone who knew how to operate on this special cancer. And it was a guy in another state. Of course, it was an out-of-network doctor. And the book is about her whole process and how she went about doing this. And there are strategies. So, for instance, if you have Aetna insurance, now with social media, put out there anybody who has Aetna insurance who got reimbursement for your therapy for your child's diagnosis. If they have reimbursed it before, there's legal precedent, and you can leverage them into reimbursing. And there are a number of these strategies and ways they go about, but the documentation, and I had a family that I treated a couple of the members for persistent post-concussion syndrome. And this mother, she was a university administrator, and she went and applied for reimbursement of the hyperbaric oxygen and got denied. And she appealed it. The appeal panel, this woman was incredible. She went through it's supposed to be a peer review panel reviewing this therapy who are experts in hyperbaric oxygen. She went and challenged everyone who was their choice about their expertise in hyperbaric oxygen, got them all disqualified from the panel, got a second higher level review to a neurologist to review the literature on this, and she got it reimbursed. So what I'm telling you is there is a way to do this, and it's proportional, your success is proportional to how much fight you have in you. Because it takes some time and energy, and I know you moms are tigers, you know, and so there is a way to do this. But go get the insurance warrior, and it will give you some kind of a blueprint on how to start with this, because the studies, I'm going to just say one last little anecdote about this. When I got into all of this, my mentor, Dr. Richard Neubauer, I saw how the medical profession, and specifically the neurology specialty in the United States, and in particular the Hyperbaric Medical Society, had trashed his reputation. And I was told I could call him and ask him how to treat one of these very first divers. He's in the book. He's here today. But one of them, and I was told, you can call him and talk to him, but don't be associated with him because it will destroy your career. I couldn't understand this. Here was a guy who had a treatment for an untreatable disease, and don't call him up because it'll have an impact on your career. So I thanked that person, hung up, and called Dr. Neubauer, and began this whole process. But the point was, he was a brilliant man in a little freestanding clinic. He had no institutional attachment. And I thought, that's a problem. I've got to get an academic attachment for institutional credibility. And so I went that route. That was the second full-time job, was the whole LSU appointment, thinking that mattered. Let me just tell you, it's been a 30-year saga. They're impenetrable. Science advances funeral by funeral. That is the famous statement of Max Planck, the nuclear physicist, when he and Einstein were developing all the quantum mechanics, and he was so dismayed they couldn't get the physics community to accept their proofing and the mathematical equations. He just gave up. He just said, forget it. All these old guys, they got to die off. That's the only way science advances. So what I'm saying is that process and that route is exceedingly slow. It's not productive. There's so many factors, and we can talk about them. And that's why I've gone to the public, like the drug companies, and mass market to the public. But it's on social media, it's families, it's testimonials, it's this. And yeah, I'm still doing the academic stuff to do that, so they can't completely discredit me. But the way is by having to go to the people, and gradually this is now multiplying. And if you go to the chapter I wrote in the first textbook in 1998, the last paragraph was about how this was going to, be disseminated through computers and the internet and so on. And that's what's happening now, is that people are finding all of this information. Look, he can't even advertise. The FDA's restricted him, and yet how many people are finding him? He's back booked how far, and more people are coming on to this. So yeah, the academic, okay, that's a route. It's very slow. Try these other routes.
And not only that, but just to give you a little window into what it looks like in order to get the research done and then legitimized. It's an undertaking, and I think that we all up here have spent our own dollars. And just to give you a little idea, right now, a company that I'm with, SNA Biotech, I'm part owner of and on the medical advisory board, we're trying to launch 9 FDA clinical trials. Just one of them, we need $500,000 just to get it started, and not only that, but so the part of the study that I wrote to get it approved to be done by Harvard, I had to rewrite it so many times, and it was verbiage, and it was content, it was this, it was stupid things that didn't mean anything. It didn't have anything to really do with the context of the study. They're going to nitpick it, right? So you have financial limitations, you have political limitations, you have so many things that they don't even care if it works or not. They're just trying to, honestly, I don't know. I don't know what they're trying to do. But when you're trying
to move a product is what they're trying to do.
Exactly. And honestly, what's going on is our product is going up. The neurosite software that we're producing for neuro rehab, it's going to compete in the pharmaceutical space, specifically for ADHD medications. And that's going to be the first FDA clinical trial.
And what kind of side effect profile are we talking about?
I'm sorry?
What kind of side effect profile are we talking about?
Oh, yeah, exactly. Yeah. So,
there isn't going to be any.
so there's a lot of people coming up against that. Now, what did we do? Because, again, we're trying to be on a global scale. Well, we know some very wealthy individuals in the Middle East. And honestly, when the people in Dubai heard about what we were doing, they said, we will absolutely invest in you. And they said, how much money do you need? We told them. They said, no problem. And so that's literally another country going, can you help our population? We said, absolutely. They said, let's make it happen. And so we should be launching the first, we're going to call it the Neurosolutions Center in Dubai in next quarter. Over in Dubai. And it was so much easier than doing it in the US. So there's so much that, honestly, like when you say, yes, we're alternative, but my God, we're trying everything we can do to make it mainstream, but there's so many things working against us. It's sad.
And it's so here, as a negation, Dr. Harch and I have had this conversation before, which is a couple kids.
Kick us out here in a minute, but finish your sentence.
A couple kids fall through the ice in Minnesota, go underwater for a long time, they come out and they're okay. So do we have cooling pads in every hospital in the United States? No. Has it been 40 years? Yeah. Well, when are we going to get cooling pads in every hospital? That's not standard of care yet. Does insurance pay for that? If it's in a hospital, they will.
Okay. Y'all, we could sit here forever, I think. But I think the video guys would probably like to go home, and I think someone wants to know if they won the laser. What do you think? This is super exciting. So I'm coming up. But thank you guys all for coming. And y'all are, oh my gosh, this is like Dream Team. Yes? Let's give them a round of applause.
Thank you.
We're so excited that y'all were all here and y'all stayed till the end. Wow, this is great.